please. Well, hello there and welcome back. If you've checked us out before on our Go With Us to conferences, in this case, it is EULAR and 2021. We at AiArthritis, we attend all of the main scientific conferences, which there are 2 each year. The American College of Rheumatology, which you can go with us there because we'll be going there in November. And then also we go to EULAR, and usually when we go to, it's some of us are in person, some of us are remote, and we have sort of this large team that goes with us and sort of helps to review, and that's what we're doing now. What our organization does best is we talk. So we will create some takeaway lessons and important points from these, but right now we invite you to come along with us as we talk about the topic of the sessions of communication with our rheumies, which is what we call our rheumatologists, or communication at large in general. So all of us, Deb didn't, this is also something that really is interesting about our debriefs. We don't always have to all go to them, just like a real conference. You might have to break up and some go one place, some go other, and some don't get to see them at all, like you at home. So Deb is representing those of you who did not get to go to the sessions, but you can still be part of the conversation, and vice versa. I did not go to the ones Katie and Patrice went to, and they didn't go to the ones that I went to. So this is just a nice way of us all coming together and sharing what we've learned. So we're going to start off talking about, I'm just giving you a kind of an update. This was actually mentioned in both of our sessions, and that was EULAR recommendations 2021 for the implementation of self-management strategies in patients with inflammatory arthritis. It was a long name. So when we talk about the recommendations, there was something interesting that I actually Googled it because I wanted to find the actual recommendations. I'm going to share my screen here for a second. And what ended up happening, can you all see my screen? I'm going to go a little bit bigger here. Well, I found this and I thought, well, this is just a really good opportunity. What we do like to also do when we go to these conferences is in layman's terms, explain the process of research. And I thought this was a good opportunity. I came across this first and thought, oh, maybe the recommendations aren't out. But what this actually is this is an abstract or a short version summary of research that was done to get to the recommendations. And it's called a systemic review. A systemic literature review, to be more specific. And basically what this was is I looked at it and said, oh, so what happens anytime you start research, whether it's a project or a process or guidance, the first thing that the research team does is they do a review of anything that's been published beforehand. So they have a starting point so they can assess what worked, what didn't, and that's what this was. So in order to get to the guidance that we're going to overview here quickly, the first step, I found the publication. So it actually, these came from starting with 1,577 references. And then you can see they basically narrowed them down to, well, these talked about problem solving in random clinical trials. This was cognitive behavioral therapy, which we've heard a lot about, goal setting. Were in 6 of these, education in 5, and the overall conclusions were there was a confirmation of beneficial effect of self-management in these interventions and important to implement them because they found all of this data that said this works. So this was the stepping stone to get to the recommendation. So I thought that was just kind of a good learning moment there. I know we all sort of have the recommendations up in front of us here. We have a summary. Did anyone want to sort of give us the overarching principles of the recommendations that were formulated?
I see Patrice nodding, so I was thinking she was going to jump in.
Yeah, I didn't print out the notes, so
okay, Deb, you have them.
I'll listen.
Okay.
Yeah, I knew the giggle was for a reason. So, so it basically comes down to there's 3 overarching principles and 9 recommendations. So, so empowering patients to become active partners of the team. So again, the team approach with you and your physician, and to take a more proactive role instead of just sitting back and letting the doctor make decisions. The importance of patient education, key self-management interventions like problem solving, goal setting, cognitive behavioral therapy, the role of the patient organizations and the healthcare providers in promoting and signposting.
Yeah, I forgot to Google that.
Yeah.
I didn't know what that was either. And I just realized, oh, there's something I forgot.
Yep, signposting. So in the meantime, we'll talk. I'm going to pull up, after I finish talking, I'll go hit it on my phone and see what I can pull up.
I think I remember that. I think it was mostly like the signs you'll see in like a waiting room, like the informational posters and stuff.
Posting signs.
Posting.
Okay, got it. Back.
Yep, thank you. Thanks, Katie, for that little side note. So just the signposting, so things in the waiting room and like probably those digital boards and things like that that they happen to have in there, and that are available to patients. And let's see, the promotion of physical activity, lifestyle advice, support of mental health aspects, the ability to remain at work or go back to work, probably.
Now, that, side note, that's a thing in Europe. That is very European specific. They have a whole social platform as part of their legislative efforts, and it involves educating the workforce and keeping people with rheumatic diseases in the workforce. So that's where that comes from. Sorry.
That's huge. And again, I wish that was probably more adaptive to the US. So anyways, digital healthcare is essential in supporting and optimizing self-management, and the healthcare providers need to be aware of available resources to signpost patients. So yeah, to actually throw out.
To put in their waiting room so we see them. Got it.
Yeah. Yep.
Okay. Well, we have some resources, so they can contact us and we'll be glad to signpost.
Absolutely.
That's a new word I learned today. Yeah, so basically what I found very in keeping with the themes that we've been talking about here is this whole holistic patient approach. We've been seeing diet and exercise a lot, but I don't know which debrief it was, but Deb and Patrice, like you all attended that one with the diet. I think Katie, I think everybody did, but myself.
Yeah.
And it had a much bigger focus, and we're seeing a lot more research on it. And that whole comorbidity, multi-morbidity, which is when the patient is in the center of, and you have multiple things that may or may not be impacted by your disease. If it's your disease in the center, that's the comorbidity. So that was, so I'm glad. So they put out official recommendations, and then I'm imagining in a couple years we're going to be reporting back how those have evolved. So
exactly, and how they've edited them and changed and moved on from those.
And we hope that they will. Well, it'll be great to see. Will they be more shared decision making that's coming up? And that's again a theme that you're going to see as we talk about this communication. We're going to jump into how to communicate effectively with the patients. That was the name actually of the segment. And one of the things we love about EULAR, and we love you too, American College of Rheumatology, ACR, but you're really behind on bringing and having the patient voice inclusive in the conversations at these conferences. So one of the things that they do very well is I don't know if I have these in order. I'm going to share my screen here. Share. Yes, let me move this over here. Oh,
there we go.
Well, that's not really the order I wanted. So hold on, not the one I wanted. Sorry. Let's try it again. And I'm going to go up here. So they had Dieter, shout out. We've talked about Dieter several times. He is vice president of EULAR, which is the organizational leg or arm of EULAR. So I'm going to let somebody else just kind of take over what he was talking about here at the consultation, because I just accidentally closed out my notes. So I need to pull those back up. Does anyone want to kind of lead on what he was talking about, what he would like at the consultation? Don't have to read, just a general overview.
All right, I'll take it. I'll take that one.
All
So I'd like to have a doctor who is attentive. So again,
Oh,
those types of things. Yep. I still have my other one, so I can, yep. The eye contact, body language. Because if you have a doctor that is like, arms are crossed and you know that they're not open to listening to you. So I think that is a huge thing. And they ask follow-up questions, or if I'm understanding you correctly, this is what I'm hearing, and you know, those type of things. Tailoring the information to what I want to know. Showing empathy, the expressiveness and things like that, you know, is aware of, you know, where I am with my disease, if I'm in early stages, late stages, things like that. And conveying the feelings of the person that is important, that it is important that they're feeling heard, things like that helps to navigate through the complexities of the healthcare system, whether that is prior authorizations or explaining terminology, things like that. And does a full examination and looks for new things that are popping up, taking complete notes. One thing I know that I always am aware of with my doctor is if they've read my notes before I'm actually in the room. I mean, there's nothing like them to open up your case and be like, give me a second. So
I had that happen. Rheumy number 2. She actually walked in and she said, well, where's your file? Well, I don't have.
Oh, let me get it on my bag here.
It was, but it was supposed to be in that door thing. So she went outside, got it. And she goes, so did you get the test? Did you go get the labs? Well, yes, 2 weeks ago I did. She said, what did it say?
Wow.
I
That's
know.
a good example.
Yeah.
And I think it's really important to highlight this last little sentence here. The doctor has hundreds of conversations, and, you know, I mean, maybe they do, maybe they particularly remember you, you've been going for a long time, you know, and they can jump on real quick, but the 10 minutes, we've talked about this in Rheumy Rounds before, when we've had Dr. Al Kim or Dr. Al, or just Al, however you want to call it. He goes by all of the above. We have had that conversation with him as far as, you know, a patient is gearing up for these 10 minutes that is going to have a massive impact on my life for the next 3 months, 6 months, or however long to get in. And
Right.
What is the doctor thinking, you know, when they get in? So that's just something that I think warrants more dialogue. And then I'm going to put this one over because this was the second one. And then he talks about, let's see, at the consultation, things that he would like. What do we have here? Without my doctor doesn't interrupt me. Do you all get it interrupted?
No,
Not at all.
not with this, my current one.
No, that matters too. Time. This is a bit time at the end of the consultation to ask remaining questions. If you have 10 minutes, that's tough.
Yeah.
How do you all prepare for that? Do you have a set of things you go in and you say, okay, I've got to tackle this before I leave? And do you get to the end? Do you actually get everything covered?
I do. Because
You look like you're going to say something.
I'll write down a list.
Katie?
Oh, I was gonna say, I have maybe at most 3 things, but I usually just focus on at least the top one. I'm not gonna leave until I get that top one addressed if I have something, so.
Okay, here comes decision-making aids again. Patient guidelines, patient information I can review at home and useful for shared decision-making. We talk about shared decision-making a lot. I don't know how many tools I've actually taken home from the office, I have to say.
So,
And I wish there was.
Oh,
What
yeah.
would that look? Oh, go ahead, Deb, and then we'll go back to Katie.
So like for me in particular, my doctor has a form in front of her and it's got a carbon copy. So she will write down, all of like everything she's noticing, what I've actually verbalized, all of those things. And she's also writing down what her examination findings are, what's different. And then she'll write down a list of like 1 through 5 or 4 and write down these are options of what we can do.
Oh,
And she will, and then, she'll put it back to me of what do I want to do? And do I have questions related? My appointments are probably around 20 minutes. I don't think I have a 10-minute with my roomie. She definitely allows time, but I love that because then that tear off is everything we've talked about. And I go home with that tear off. So there is total shared decision making. These are the options, of what she heard and what we can do and where do I want to go with that? She'll put it back.
Question. Do they involve some of the points of the guidance that we just talked about at EULAR? Are they treatment specific, or do they talk about exercise, mindfulness, anything like that?
All of that's encompassed into those points.
Wow.
Yeah.
I guess that doesn't happen with Patrice based on that response.
I'm sorry. Yeah, it is. And activity, because I'll even mention like the last appointment, I was like, yeah, my husband and I are very intentional about getting outside and walking for at least 30 minutes and how that feels with my feet, because I've just had the reconstructive foot surgery and not pushing it. And then she'll kind of address different things. Do you think you can build on that? Or is this where you need to be right now? And all of those pieces.
Okay.
And then treatment for sure.
Katie, did you have anything to add?
Oh, no, I was just thinking, like within that 10 minutes, you don't have necessarily like the time to absorb all the information or think of everything you want to think of. So to have something to take home and to review at your leisure when you can, and other resources to like understand it better, I think that's kind of a great tool.
Yeah. So a funny story, Rheumy number 3.
What are you on right now?
I was just going to say, how many have there been?
I'm on number 4, and
Okay.
I will have him forever unless he retires. But anyway, Rheumy number 3. So when I was asking her a bunch of questions, she just looked at me and I said, so what are we going to do about it? She said, bleh, bleh. She's typing on her computer. She says, that's all we have for time for today. And I said, wait a minute, I'm not done. She had
Really?
yeah. And then I just said, well, fine. And I just walked out.
And that's why she was Rheumy number 3 and
Yes.
there's now Rheumy number 4?
Yes.
It's terrible.
I know.
I was looking at, I don't actually go over my labs at my consultation or my doctor's visit because I usually get them ordered at the doctor's visit. And then I just go onto my portal.
Yeah, I do too.
Mine puts notes in there.
Yeah.
She'll put notes in, and she'll, if anything is elevated, she's like, let's recheck in 2 months.
Yeah. That's that, because I can't wait 3 to 6 months to get my findings from the
No.
from the last time. But I'm not going to share that screen just because we have good information up here right now. There was another slide that he put up that said, I guess this is kind of what he wants, and it said, what do we expect from an appointment with the doctor, and then put a big we up there as well. So I mean, this is kind of what he'd like. So then we look and go, I'd like this. I'm like, oh, I get, okay. So these aren't actually, I mean, this is his opinion. I think that's a really good point to put out, that we all have different expectations of what we want from a visit. And if a doctor just comes in the room with a preconceived notion of what that endpoint or outcome is going to be, how does that impact the we if there's no one size fits all? I guess
Really good point.
That's the question. So let's ask everyone. So I'll start. Well, I'll let somebody else start. So if based on whether it's on here or not, if you're just thinking a listing like the top 3 things or whatever that you want from your appointment, what would it be? Let's start with Deb.
I think being heard. And she knows, so since I've been with her, she wants to lower my prednisone. And I'm on 6 milligrams, and I've never been off in 38 years of having this disease. And she feels my apprehension because I've also, that is one thing, again, it's part of every visit that she talks about it. And if I'm feeling better, then I will start to taper. And tapering doesn't work well for me. I usually hit a hard wall at like 3 milligrams, and I've always gone back up. Yeah, I know. So, and I've also heard, again, with reading about it, my apprehension is that your adrenals will completely shut down, and that's kind of what's inhibited by your steroids. So it freaks me out. And she's like, well, I'd like the opportunity to try without that, without any outside help from anybody else. And she knows, and she's like, well, will you at least give me the opportunity to try? Well, I'm like, okay, but still, that still freaks. And I haven't done it yet because I've never been in a good enough shape to be able to start tapering. But that's kind of where my apprehension is. And she knows it. I mean, she knows it's there. But again, we do all the shared decision making about everything else. And she also, on that sheet of paper that tears off, writes down what specifics, if I were to start to taper, I would do 0.5 milligram taper every other day, and those type of things. So she's pretty thorough. She really is.
So listen is on your top.
Yeah, that is a huge piece, is listening and also, understanding what is worrying me.
Listening too. Understanding, listening. Yeah. Those are just good communication skills, really.
Right.
If you just summarize it. What about you, Patrice? And we know it's oh, what's happening? Are we getting bombed? Are we getting bombed by a doctor?
Ooh. Well, wait a minute.
Well, look who it is. Oh no, what's coming on?
Wait a minute. I thought we were logging into the annual conference for best practices of disposal of kitty litter. We're definitely in the wrong room.
Well,
where am I? We got the wrong link. We got to get out of here.
Well,
I don't know what's going on here.
You guys are both in the office on Saturday.
Yeah, pretty much most Saturdays.
Okay, well, so Patrice, when I was talking about a surprise, I actually knew they were coming. Well, I didn't know Jeff was coming because he has a really tight deadline. So thank you for squeezing it.
I keep the suspense up.
So we are in the middle here of, we do these debriefs of patient-led debriefs on the sessions that have been happening at EULAR. And
not kitty litter. No. Fine. I'll talk about this.
Oh, so as we were actually just on the topic of on the sessions of how to effectively communicate with your patients. And we were talking about what we like from the consultation. And then they were in the session, the doctors were sort of talking about what does a doctor plan for. And I think this is a really good time to just ask you all, because we were just saying, we only have these 10. I feel lucky. My rheumatologist, I usually get to see for like 20 minutes or longer, which is Al.
I do too. I
you don't all know. So here we have Dr. Al Kim, Dr. Al, or Al, who he is known for. We also have Dr. Jeffrey Sparks joining us today. So thank you.
Also known as Sparky.
Oh. Well, that's new for
also
me.
known as Alfredo.
And Al has been on our talk show many times. We've had the honor to have Jeff on there as well when we talked about COVID. And I thought, if we're going to talk about patient communication, with our rheumatologists, why not invite a couple of them to the table to go over with these debriefs? And so in addition to that, we also, Jeff had won an award, which we did a shout out in our first EULAR review on an abstracted COVID, and Al has some amazing research happening with COVID. So we thought, what a great opportunity just to have them also talk about that. But before we get to it, let's finish the conversation on the communication. So essentially, we were talking about you get 10 to 20 minutes with your doctor. It is like, we prepare for this. We have all these questions we're coming in with. Shared decision making came up as something that's super duper important, but does every doctor do it? So I'd like to ask both of you, and we'll start with Alice, my actual rheumatologist. What does a doctor plan for when you're going in for that 10 to 20 minutes?
So essentially, we're looking at macro therapeutic issues. I think that's the first and foremost. Have we optimized medications, particularly steroids? Everything is trying to get everyone off of steroids. So, we have kind of a macro plan in place over months or even, past a year, where we think it should move to. Of course, there are a lot of surprises. And so we are trying to develop contingency plans around those surprises. So to me, that's like the first thing I look for. The second thing that I look for are like health maintenance issues in rheumatic diseases. Cardiovascular diseases remains the leading cause of death. And so minimizing, trying to optimize blood pressure, lipid profiles, these kind of what we call healthcare maintenance issues. We're just trying to make sure that we're moving in the right direction, or if we've met goal, trying to develop a plan to be able to make sure that if there are any side effects, how do we manage them? Or if there aren't any, then it's perfect. The one that is really difficult to anticipate, and this is largely what ends up coming up as this discussion for a lot of patients, is more of the experience or the emotional aspects of living with disease and its impact and quality of life. That is very highly unpredictable. Also, we don't have a lot of tools to be able to address them as well as we can address the other two topics I brought up before, right? And then nested within there are going to be any new complaints that, of course, we can't anticipate for that either. So, to me, like the first two things, I feel like we can, cover pretty quickly in 5 minutes, and then we try to focus the rest of the discussion on then the issues that you bring in that you feel like are important that need to be addressed at that visit.
Okay, Jeff. Similar? How do you?
Can I ask Dr. Kim a question?
Yeah, absolutely.
Or Al, you can call me Al. Yeah.
Okay, hi Al.
It took me a couple months. That's why the progression, Dr.
No, it took you a lot more than a couple months.
So I have had RA for 10 years now. And you had briefly just touched on the emotional aspect of the patient, which I am so glad I'm seeing more and more of that. And I'm so glad it's been addressed. I do have a degree in psychology, but as a person, we all have very low moments in our lives, whether it's dealing with our disease or just what's going on in our lives. And that, to me, that all factors. And then the stress also all factors in with how I feel. And also, as a person who maybe about 4 or 5 years ago decided that life wasn't worth living. And so that could probably be a whole nother talk show, but I'm just glad that you as a rheumatologist are recognizing that. And thank you.
Yeah, I think we try to address it. We don't necessarily know how to fix it. And that's kind of where my frustration then comes into play. I mean, there's also the flip side about, the days that Jeff and I have, like if we get a big grant doesn't get funded, or, it's just, career things or even personal things happen. We're trying to do our best to shield ourselves from exposing that to you guys, because it's really about the patient. But I do have moments where I feel like I don't want to deal with anything else. My bandwidth is saturated. But unfortunately, we can't choose those moments. So there is that side too about, kind of the
human, a very human aspect to it as well.
Yeah.
That's a great point. Okay. So Jeff, tell us about how you prepare for that 20? How long are your typical, by the way? Are they 10,
20-minute
20?
return visits,
20. Okay.
40 minutes for news.
Okay.
And actually, I think that's something that's always on my mind is there going to be adequate time? And I actually really appreciate when patients are really prepared and we can really optimize all the time we have together. And obviously there's a lot of extraneous factors as far as travel and parking and vitals and forms. And it's actually relatively rare if we actually get the entire 20 minutes, right on schedule. And obviously some patients have really, complicated visits that obviously can push things around. So it is really a delicate balance. And I tried to, it's obviously a balance. You want to give all the time and attention you can, but certainly there's some patients you could spend many hours with and it's just not feasible for that. So I think that is something that's inherent to our medical system at the moment, at least. Maybe there's people who can solve that. But I think that the two things I really want to accomplish at every visit is to really get a full interval history between the last time I saw them and to really make sure that the medications they are taking are what I think they should be on. So I really spend a lot of time about medications, and I like to hear from my patients to say, what are you taking? When are you taking it? How many pills? Because I think it's really easy to just sort of assume that they know what you're on, and it's really, there's a lot of communication barriers. So I like to really just nail that down, really early on, and then getting the interval history. And if there's someone where things are going pretty smoothly, that's 30 seconds. But obviously, if there's someone that's had a rocky road and haven't been there in a while, that could take many minutes, if not 20 minutes or more. So I think at the very bare minimum, I want to accomplish those things, and obviously getting a really accurate assessment of what is their current disease state as far as whether they have inflammatory arthritis or vasculitis or whatever organ is involved, and obviously surveying for other ones where maybe the patient themselves might not be super aware of, and trying to think about which labs and imaging might be pertinent to try to sort of catalog sort of their involvement. And then certainly the health maintenance is something I want to broach at every single visit. But as you can see, that the 20 minutes just can really go away quickly, and that's why we see patients many times. And I think sometimes you just have to recognize you can't accomplish everything in 20 minutes, and maybe coming back in a few weeks or a few months, even if things are relatively stable, is a really good idea. You'd rather have more time than not enough.
Right. I've got a couple things here that I do this. I write a lot of I write a lot of notes.
I really enjoy when patients bring their list.
One of the themes of EULAR has been, and I saw it at ACR too, but it was definitely magnified here, was comorbidities. And then they also talked about multi-morbidities, which was putting the patient in the center when you might have something like anxiety that's not disease related. So, you're dealing with these other issues, but they also started talking a lot about this holistic treatment, a lot of diet, a lot of exercise, a lot of mindfulness therapy. As rheumatologists, so we're seeing all of this, right? And we're going, oh yeah, let's talk about that. But when you all are still as rheumatologists, it seems very, you have that little bit of time to talk about is your biologic working, and should we be tapering you off of prednisone, and where, if at all, does the holistic approach come in with either of you, or how are you as rheumatologists supposed to start to be expected to fit that in? We're seeing you're supposed to. Now, how does that work in reality?
I guess I'll start off. It's really hard, actually. And this is part of the reason why, at least within our lupus clinic, we're trying to find resources, i.e. fundraise, to be able to bring in people in like dietitians, physical therapists, even people who do yoga, to be able to then provide those as resources through the clinic. Because I think patients do look at their medical offices as being able to kind of be the central hub for wellness also, when we're not really equipped and frankly not even trained to be able to provide that. But, you know, since we aren't, you know, as good physicians do when we don't know what to, you know, do, but we at least can point in the right direction where we need to take that person to. But oftentimes that is very disjointed in our healthcare system in the US. So it's hard for patients to be able to then find something that they can trust. So what we're trying to do is say, okay, since we're partnering with them, you know, you can trust us because we trust them. So it eliminates some of that kind of the uncertainty of making that right step. But this is really hard. I don't know how you guys are doing it, Jeff.
Well, it's hard as well. I think an ideal would be to have, you know, a lot of these, you know, dietitians and physical therapists really, you know, almost like you know, the patient sees everyone the same day, kind of multidisciplinary, and really gets to delve into the details. I think there's some places that are kind of getting closer to that, but, you know, certainly we refer to a dietitian or a physical therapist, and, you know, again, there's a lot of barriers as far as what happens when you write that referral and what really happens, as far as a lot of people never see them, or it takes many weeks and months and the opportunity is sort of lost. So it does mean that in that room, if there's an opportunity to try to, you know, broach those issues, you know, we certainly do to the best of our abilities, you know, in the limited time frame. I have to say, I actually do try to broach physical fitness as far as just what are you doing, and trying to encourage, you know, anything they can to, you know, either maintain or increase physical activity as part of my sort of health maintenance regimen. I think diet's a little trickier just because it's so complex and could take up a lot of time. But yeah, I don't think we have necessarily a much different solution, but it is something I like to talk about with patients. And some patients, it's a real priority. Some patients really don't want to broach it, and a lot of people are in between.
Yeah, I see that almost as an opportunity of organizations like ours that are led by people living with diseases, possibly being able to be that middle person or that stepping stone to help our rheumatologists, or our rheumies, as we call them, and fill in. I did have another question, Jeff. You said, and I think that Al feels the same because we've talked about it. When a patient is prepared, it's good when a patient is prepared. What does that look like? What's the ideal of a patient being prepared from a rheumatologist perspective?
Well, I mean, the ones that come to mind are really the ones that have, you know, 3 to 10 questions. Sometimes it's 30 questions, but, you know, I think actually just figuring out, you know, why am I on this? Like, some of them are, why am I on this medication? Can I go off this medication? What is the purpose of this medication? You know, what is the, you know, 6-month plan as far as medications go? You know, should I, you know, some of that's really unrelated to rheumatology, you know, had some digestive issues. Is this something that is, you know, and obviously we can give advice, and sometimes it is related to rheumatology and they didn't really realize it. So I actually enjoyed that myself. I don't know if you want to add anything to that, Al.
Yeah, so it's always the biggest challenge for us time-wise, when people come in with that list of 10, 15 questions, and you're trying to address each of them as specifically and as thoroughly as possible. We are trying to change to a model where there's more free-flowing communication. But I think Jeff highlights an important point about the willingness or the acceptance of patients to want to do that. A fraction definitely would want to do that. A fraction doesn't want to think about their health and disease until the visit. So that type of mechanism won't really work for them. And so, but they still have the similar level of problems and the quantities. So, you know, I'm not 100% sure how we address that aspect. And, you know, Tiffany, you mentioned like, oh, you know, there's an opportunity here for, you know, patient advocacy groups to be able to do this. But again, you still run into the same barrier that they're going to select themselves out potentially because they just don't want to deal with it as intimately as you guys do. Right. So again, this is human nature that, you know, we are still trying to understand. If we were able to fix this, and then, you know, then we wouldn't have this problem. But but it's interesting. To me, it's very interesting to see, these differences in, how the relationship of self to health.
Mhm.
And it's just, you learn a lot about people on our end for sure.
Can I ask you guys a question? I think, Jeff, it started with when you were talking back a little bit about just patients and medications and, the pills and not assuming. Do you, I mean, I'm going to come right out and ask it. Do you have issues with compliance of patients with medications that you're assuming they're taking their meds, and outwardly you're like, this person should look a lot different if they were taking their meds? Compliance. I mean, do you guys?
Adherence.
Yeah.
Which
adherence
was
and
covered
compliance.
actually in that EULAR session, was it?
Right. And actually, complying to actually take the medications and things like that. Do you run into that?
Yeah, absolutely.
Okay. I was just curious about that because, again, you guys are looking at what the chart says that they're taking and what they may, and, accountability and actually them being honest with you guys.
Yeah, this is not a shock to any physician, I think. And we'd rather know than not, honestly. And, when you see a patient 2 months after starting methotrexate, and then they say, well, actually, I was scared to start it and I never actually did. That happens. And
thank you
if you
for
think you're on methotrexate and you never started it, that's going to be it's just not going to lead anywhere good. So, I tell them, I just really want to know what you're taking and try to figure out the best plan to make you better.
Mm-hmm.
And if you really are not going to, if I'm going to be seeing you every month and you're going to say that I'm not going to take the medication, we got to get you on a med that is going to be agreeable to you. So.
Is that the core education, do you think, about them knowing more about the medication, like methotrexate, for instance, starting on the pill form versus the injectable, or?
Well, I really just try to, everyone's got their own style and it's obviously case by case, but it's really sort of, I'm really like, well, what were your concerns and what can we do to address those? And sometimes they just say, I am not going to take it. So then you move on to a new strategy. So instead of having that conversation, for a half of a year, or maybe I think they're on it for that long, it's really going to be better for everyone if we just get on the same page.
Yeah. So we just published on this actually with Jarek Leong, who is a Master's of Public Health graduate from St. Louis University. He's actually moving down to Emory to continue his work, getting his doctorate in public health. But he had done some qualitative work, which means a lot of interview work with our patients. And one of the themes that kept on coming up was intentional medical non-concordance. So we don't use the word compliance anymore because that's a paternalistic term. Adherence is even starting to fall out of favor. The term that I'm now aware of using is now concordance, because that implies the shared decision making.
Yep.
But so he found out it was actually eroded and very poor communication avenues between the provider and the patient that then leads the patient to make their own decisions about what to do with certain medications. Because in lupus, we see this, it is rampant. So our own internal analysis, and this matches what other lupus centers have seen, that even though we can tell that they're picking up their scripts, 70% of them have, this is for hydroxychloroquine within the lupus world, have blood levels that are half of what we would expect. Now, you can certainly make the argument that some of this could be biologic differences in metabolism, but that can't explain all of them. So there's definitely this is a major theme in lupus, and it makes you wonder, when you look at trials now where our control rate is like around 40% response, whether or not some of that 40% may be because they weren't taking their medications before, now they are because they're incentivized, because they're part of a clinical trial and getting paid to, and they won't get paid anymore if they don't, right? And, so again, there's a lot of these things that are being discussed within the lupus world that probably is true for, most chronic diseases about this issue. So, so I put the link in the chat.
Thank
Yeah,
you.
maybe if you guys want to put that with the description on YouTube, then
Yeah, absolutely. And it just really in keeping with it, which is what I was gonna point out I'm looking at the notes from the session there. Again, it was called Adherence and Belief, but let's say in concordance, it says we know patient empowerment in the treatment plan equals higher adherence. Shared decision making is the key element and important part of belief that a patient will continue the treatment that is right for them. So that was sort of the takeaway from the session. We just keep seeing the shared decision making over and over and over. And it's great to know that there are rheumatologists out there who are practicing that. But we also know, I'll just leave it at this, we also know just from being in patient groups that there are still a lot of doctors that it's like, this is the way it is, and do this. And then the patient doesn't have, they don't know enough to ask questions. And you know, it's just, okay, thank you. they move on. So I did want to ask one question, then we're going to go over to COVID real quick. It was another session that Katie did a really good job of covering here, but it was called, I think it was called When I Saw a Patient with a Rheumatic Disease for the First Time, What Has Changed in My Clinical Practice During the Years? And it was by Ian McInnes, the president of EULAR. So I don't know if there was anything, Katie, you wanted to point out specific or in there, but I thought it'd be fun to ask Alan and Jeff like their opinion on sort of what has changed in over the years, and you know, like how you've changed and how you've seen the practice change.
Well, I know in that session, he kind of touched on language and technology and things, you know, you have to adapt to how people talk about certain things. And, you know, I'm sure way back when he started, because he made a joke as far as, you know, how long he's been doing it, to say you Google something, you know, that's a newer kind of thing.
That still
And,
happens.
and yeah, and for newer technologies, I think you said something as far as quantum something, like how do you know that language, and then how do you know how to communicate that then to the patient? So I thought that was kind of interesting, like the ever evolving just language of communication, terminology.
yeah, that's interesting because, you know, one of the hardest things that we do with our med students is that they're being taught at the technical level. But we don't really teach them how to colloquialize that for patients and the public to then provide their input. But then, of course, the feedback, the data that we're getting is going to be colloquial. And sometimes there's errors in translation when you get back to technical, right? And so this is, you know, it's, you know, the more experience they have, the less of an issue this becomes. But again, we see this a lot with our trainees. I mean, you guys probably have experienced it when a younger physician comes in and they start using words you don't know what they mean. Right, you know, that's probably like a really good example of where they're not doing that translation for you, but certainly a barrier.
Yeah.
So he, at the end of the session, and I'm going to quote what he said, it is far more important to know what person the disease has than what disease the person has.
Yeah, I think that's really accurate. That's a very clever way of putting it.
Yeah.
What about you, Jeff? What have you seen, kind of the biggest changes you've seen in where rheumatology visits have gone over the last, you know, several years, the evolution, if you will?
Well, everything's becoming more complex, as in everything in life. I feel like the documentation has been mostly a hindrance, honestly, as far as that quote is concerned, because there's just so many boxes to check, and they change the medical record all the time, and there's all these quality measures, and a lot of them are well-intentioned, but it just creates an incredible amount of bureaucracy that lands in the physician's laps. And again, all that needs to, in an ideal world, it would happen in that 20 minutes, but honestly, it happens in that night and the next day when we're still completing notes. So I think that's been a big difference. I know when I was a resident, my notes were just basically completed in real time. And now seeing 15 patients in a half day, it's just not going to happen.
Wow.
And I think that does get in the way of the humanity aspect of medicine.
That's a really good point. So this is our segue into COVID. So COVID has come into play.
Always
very
working.
Yes.
I mean, for the world, but I mean, here rheumatology, has definitely come front and center on here. So I thought, as we're talking about the shared decision making and understanding COVID and, the vaccination, I thought maybe, Jeff, you had an awesome abstract that award-winning, that from the COVID-19 Global Rheumatology Alliance. I thought maybe, you could tell us a little bit about sort of the key takeaways, because I think that ties in here too. I mean, we need to communicate those back to patients, and how that affects, knowing this, having this knowledge, how does that affect the visit? So I'm going to turn it over to you, Jeff, to give us a little overview of this.
Well, sure. I think we were trying to approach, something that I get asked about all the time still, and that is, how are my medications, how could those affect my COVID course? And so, we've actually been thinking about doing a study probably from the very beginning of the GRA. And part of it's that we wanted to do it in a single disease where all the drugs that we were studying are really, being considered for treatment for that disease. So for instance, if we had lupus patients, it's a different menu of medications. So that's why we really stuck with rheumatoid arthritis, and certainly it's one of the most common, systemic rheumatic diseases. We also limited the menu only to kind of the advanced therapies, biologic and targeted synthetic DMARDs, which are JAK inhibitors, just because we kind of want it to be a bit of more of a fair playing field as far as, really you start methotrexate at the very beginning of rheumatoid arthritis, and it's just a different disease state. So we really wanted to get people kind of in a kind of similar disease state. So we limited to those medications, and we basically asked a pretty simple question: is if you were on those medications at the time you got COVID, were there differences in how severe the COVID course was related to getting hospitalized, getting oxygenation, ventilation, and unfortunately dying? And what we saw is that the most common drug was the tumor necrosis factor inhibitors, the TNFs. And we compared all of the drugs to that drug class. And we found that patients who were on rituximab were at increased risk of severe outcomes, which is something we probably expected, because that is probably the drug that impairs the viral defenses the most. The other class of drugs that we found was the JAK inhibitor class, which was a bit unexpected. This hasn't really been broached yet. And we found that it was associated with more severe outcomes. And this has been even more interesting because in the general population, there's now been several trials that show that JAK inhibitors can actually treat COVID. So this really deserves a lot more study and replication, but certainly taking it at the moment you get infected versus choosing to treat someone, when they're in the hospital sick, needing oxygen are a bit different.
Right.
The other classes of drugs were abatacept and interleukin-6 inhibitors, and those really had no difference between the TNF inhibitors. So that's the short version of our abstract, at least. So
that's interesting. This just came up in a patient group like this week. I had made a comment about the steroids and that some of the early research in showing that there are poor outcomes, and that's why the rheumatologists were trying to get down to a lower dose. And somebody was very argumentative to say, well, steroids save people with COVID. And I had to try to explain that same sort of continuum that you're talking, the phase 9-10 COVID, that they'll come in. But it is ironic that some of the treatments we're seeing, just like the JAK inhibitors, that's coming in to help. It's very strange how in the early phase it's just different.
Yeah, it's a matter of timing. And immunology is very complicated, as Al can attest to. And I think I think it really makes me want to vaccinate everyone, which is a good segue to Al's work, honestly.
There you go, because that's where
Yeah, for sure. I mean,
Yeah.
I've read a lot of your publications, which are amazing, especially for folks like me that finding my, again, I know it's not a magic. I'm part of the John Hopkins study that they're testing antibodies, and it's so reassuring to again, don't love the outcome, but it's reassuring and for what's to come. And I'm just anxious to see where things come, because I'm one with very low antibody levels at this point. So anxious to see where this all comes.
Yeah, so I want to finish a couple thoughts about Jeff's work, because I think this is really the Rosetta Stone for understanding the kind of the correlates of immune arm activation that's required for outcomes, changing outcomes in COVID-19. And Jeff hit it on the spot. This is all timing, and it's not about the confusion about the therapies. To me, it's more that COVID-19 is so unique in that it is the inflammatory environment it creates in the late stages, the more advanced, severe stages, is really pronounced for any virus infection. And so that's where it's a little bit confusing. So definitely early on, you get rid of B cells. We know antibodies are important for control of early COVID. There's really great work from Ikuku Iwasaki at Yale that really nicely showed that the timing of when you generate antibodies, not the type of antibodies you make or how well they work, the timing early on is the biggest risk factor for developing COVID. If you are late developer, you will get severe COVID. If you develop them early, you will most likely not get severe COVID. And so that's the reason why these B-cell depleting therapies totally make sense. But the JAK inhibitors, to a certain extent, also make sense. And we're going to make an assumption that people are going to watch this are going to be sophisticated in a way that we can have this open discussion the way we're thinking about it. Because the interferons, which are basically antiviral proteins created by the immune system, its activity is blocked partially by these JAK inhibitors. So again, the story is the same, that one of the earliest immune observations was that if you had good interferon responses early, you're able to control disease. You had poor interferon responses early, then you weren't able to control disease, and you were a higher chance of developing severe COVID. So all of this, I think, is really reassuring. It actually is critical because a lot of the early mechanistic studies were very, very small ends of people. So we really needed a validation in a much larger population. And so Jeff's work, applause, is really critical to really cinching this entire argument. But also, it helps, COVID-19 has an unexpected, increased inflammatory environment state at the late stage. And so that's also then the reason why anti-inflammatories seem to be effective late stage. So that's, again, it's complicated because it's not just one box. It's two boxes within another larger box, right? Mm-hmm. And they do kind of, they operate somewhat independently of one another. So that's the complicating feature when you're trying to, colloquialize that. So.
Right.
Yeah,
and we'll share the links for your research, both of the research, and actually, Jeff, just as an FYI, we just yesterday, our organization in partnership with EULAR and groups in COVID and international scale, we launched the pathway of patient engagement in rheumatology research, and the stop on the pathway of 2012 was the innovation of the COVID-19 GRA, and we actually linked to the presentation on the abstract because it made the pathway because patients are it was the whole patient collaboration of the GRA. So I'll make sure that, but we just launched that yesterday, and I wanted to make sure that you all knew that, and we'll for sure link to these. And then I just wanted to also just kind of ask, since we're on this thing of communication, what are you all, I know as a person living with the disease, there's so many questions still. I think we're nowhere near the end of the conversation with COVID vaccines, because now we're starting to hear, do we have to have a booster? And these conversations are coming up. As patients and rheumatologists, how can what should we be preparing for coming into these visits? Are there anything that you all are suggesting that we start to prepare for? I mean, there's just so many still unknowns, I guess. So as we're talking about communication, if you have any recommendations for us or for people out there to prepare for this continued evolution of COVID and vaccination?
Yeah, I think we have to still be patient. Answers will be coming out soon, but the biggest, so for, I'm still actually, so this goes all the way back to whether or not you even get tested for antibodies. All right, because I think that's the kind of the core, the very first step that then leads to a lot of things downstream. And I'm still in the position where I feel like that the results are inactionable. If let's say you have antibodies, while they're very important, many immunosuppressives also affect many other aspects of the immune system. So there is a theoretical risk that has not been demonstrated, but a theoretical risk that even if you have antibodies, you still may not have optimal protection. All right, so there's that. But then flip side, which is going to be of bigger concern to people, is if I don't have responses, then what do I do? And the problem is that, there isn't any actionable thing that we can do because, if you're going to give prophylactic monoclonal antibodies, as Jeff had proposed earlier, a few months ago, the problem is that they're still under an EUA or emergency use authorization from the FDA, which substantially restricts its use outside of its indicated or approved usage. And the same thing with boosters. Again, that's also, all the vaccines are still also under an EUA. So, but I know that I have some patients that have gotten boosters on their own because they lied about whether they got vaccinated in the first place. So this, that shouldn't be surprising. That shouldn't be surprising.
Don't ask, don't tell.
Right? Yeah, this shouldn't be surprising to anyone, right? A, we're humans, but B, and this is the reason why we're still advocating not to get tested, is that, people will act on their own if they believe something strong enough. I mean, hydroxychloroquine wasn't that long ago. Right. This is a really good example where inadequate information about how well it worked was completely overwhelmed by the narrative of its potential. Right. And people then conflated or basically substituted that potential for the actual information, right? Because there was an actionable item that you could do with that at the end. And people feel like that, I don't know why, that we have to act on everything, all right? And so this could lead to misadventures amongst the patients and I already know I have a couple patients that even tried to look for immune boosters on the internet, whatever supplements or additives, which obviously is interesting because we're not trying to necessarily boost their immune system because that's what's actually causing their disease in the first place. Right. So again, it's being able to think through those things. But again, the emotional aspect of what COVID has done, has really even, probably accelerated the need to act on something, right? And that could lead to, negative outcomes. And so this is, again, goes back to, even getting tested, unless you have a level head and can just say, okay, I know I don't have antibodies. I'm just going to sit here and wait until we know what we need to do that can be safe and effective. All right. So that's, I think this is human behavior to me. We see it all the time as providers too, with patients and them making decisions about what they want to do about their disease. That isn't necessarily an option that we had discussed. Right. This happens all the time. So we just have to be ready for when certain trends then become more than just little pockets of interest and become actual fads.
That's really scary. And actually some of the ones that that actually went and got vaccinated again, did they get vaccinated with the same product or did they go to a different one?
Most, this is going to be very state dependent. In Missouri, we're still pretty dominated by Pfizer. Yeah. So okay. Most of the time it's that. I will say for boosters, there is, and I don't know how 100% if this is public domain knowledge, but there is discussion about a booster trial through the NIH for rheumatic disease patients on select immunosuppressives. And so the protocol hasn't been finalized yet to my knowledge. So that's part of the reason why no one's really heard about it. But this is something we're certainly going to be participating in, and essentially is going to be certain diseases and certain specific type of medications, such as rituximab, which destroys, and then giving them a booster, but it may not be the same. It may be what we call heterologous. So basically, it could be different. So they're actually setting up arms where a third will get Pfizer, a third will get Moderna, a third will get J&J, regardless of what you got before.
Yeah.
All right. And then be able to follow up for about a year. It is interesting, though. I mean, and Jeff, these are the type of discussions Jeff and I would have over probably starting the third or fourth cocktail.
This is like the actual EULAR experience now.
Yeah, I know.
Well,
that's got to be next, because this is like the second time the Al and Jeff and I have been doing. We were on cocktails came up, and I said we can arrange that. We can
they always come up.
Debrief.
Yeah.
Well, as an aside, that's an important part of these meetings. A lot of times, future directions, collaborations, studies get mapped out, after hours, and
a talk or a poster, you're just like, I don't understand it, or this is really interesting. Could it actually be true? But this is so the type of discussion I was going to say with Jeff was like, it's interesting because rituximab in general is considered to be a really safe drug. There's no increased risk of serious infections with it compared to many other therapies, and it's just interesting to note that in this very specific environment, of course, few vaccine studies have been done, but Ritux was obviously a big problem. But it's just interesting to see now, how my own perception about B-cell depletion has changed quite a bit over this past year, and but it's a problem because I like using Ritux a lot in African Americans with lupus, for example. I think it's still very effective. So this has become kind of a, I'm trying to reconcile. I'm trying to unpack all this. Like, what's my next thing I'm going to do? Like, do I continue to prescribe it? Do I continue to, counsel patients that in general it's safe, but COVID, right, is a problem.
And that goes right back to the whole shared decision making too. What is the patient? I mean, do they want it? What are their benefit risks when you're talking about that? In interest of time, and I know Jeff has this super duper big deadline as well. Is there anything else that you wanted to add to that Jeff, about kind of this whole conversation with COVID and patients and being able to prepare for the new wave, I guess, of visits?
Well, it feels like there's been the waves of COVID from rheumatologist perspective are early in the pandemic. What do I do with my meds? And then it was, what about the first vaccine? Then it was, can I get antibodies checked? And now it's going to be, can I get a booster? So that's the four waves from a rheumatologist perspective of the discussions we've had over the past year and a half.
And they're just going to keep we don't know what the next one is. What I'm gonna just mention, I just wanted to do a shout out and thank you for support of from J&J Janssen. Our organization did just receive a grant for shared decision making in helping patients when it comes to COVID and vaccination decisions. So
that's a booster.
We're the booster decision, and that's actually what we said in the grant.
That's exactly the boost I need.
Yeah, there you go.
No more human interaction for the rest of the day, Jeff.
Yeah, we don't.
For that one.
This is a moving needle here, but we'll do our best to help navigate them through. But there you go. So I think that we have in the first ever, we've been doing these go-to conferences. We do this for the ACR and for EULAR. We've been doing them for a couple years now. First time we've had other stakeholders other than patients come and join us. So we really want to thank you both. This has been that's what we like to do though as an organization. All stakeholders at the table having conversations, because we think that's the best way to really solve problems. So
thank you for the invite. It's always fun.
Yes.
I know.
Thank you very much. I think the biggest lesson is to have patience. As a patient, to have patience. Throughout the whole COVID, this whole COVID thing, it's just the matter of just being patient. And I think I was on lockdown for so long, and comfortable doing it, but it's time to start to just, you know, again, still hand washing and all that stuff, but get back to life a little.
Yeah, absolutely.
But
So-
thank you guys so much. This was really great to have you guys here.
Thanks for having
Yep.
us.
And for everyone else we still have who are watching, we still have a couple different debriefs that we're going to wrap up for EULAR that'll be published, and then we will call it a wrap and continue with the debriefs when we go to ACR in November. So I'm going to stop the recording here, and thank you all. We'll make sure that we post the links with this post as well to the wonderful research that said. So signing off from EULAR.
Bye, everybody.